of Manchester, and I am hosting today's webinar on behalf of the UKRI Transdisciplinary AMR network, which is called the People Network. I'm just waiting until the slides appear before I move on. There we are. Thank you, Alistair. So this is the second in our webinar series, and today's webinar is about the transdisciplinary approach to co-developing an infection prevention and control training app for veterinarians. So that's for use with companion animals, I believe, although we will find out more later on. I will be introducing Professor MacDonald from Glasgow School of Art and Dr. Akiri from the University of Surrey School of Veterinary Medicine. If you could go on to the next slide for me, please. So the People AMR network is about putting people at the centre of antimicrobial resistance and the appropriate use of antimicrobials. So this is about prescribers, it's about service users, not just for human health, but also, as you're picking up today, for the owners of animals, the people who use antimicrobials maybe with their pets, and communities more generally. So People is an acronym that stands for Developing and Evaluating Multifaceted Evidence-Based Interventions to Promote Prudent Antimicrobial Use in Community Contexts. So this is outside of hospitals, it's outside of healthcare settings, really. It's about outside of the hospital setting and the community setting, about stewardship. Can you go on to the next slide, please? So we are led by Dr. Sarah Tonkin-Crine from the University of Oxford, along with Professor Gail Hayward, who's an academic GP, Alistair and Abel, who you're about to meet next, myself, who I'm a clinical academic dentist at Manchester, and Chika, who has admitted us all today into the meeting, and without her, none of us would be here. So thank you very much, Chika, for setting all of this up for us and making it work. If you could go on to the next slide, please. So our target audience is everyone in communities who uses antimicrobials. So you think about in your own personal life, you start over on the right-hand side, you may have relatives in care homes or children in school nurseries or at home. You may have animals in kennels and catteries. You may even be a farmer. You may visit farms. You may take your children to farm days. And then we have prescribers as well. So I'm a prescriber in dentistry right there in the middle, of course. Over on the right-hand side, primary care, which usually means primary medical care, and pharmacists. And then we have vets for small animals, companion animals. So you can see that looks like a rather nice retriever maybe in that picture. And then large animals, so sort of herd, dairy herds, for example, sheep, goats, whatever they're farming. So they're using antibiotics in a rather different sort of way. But we all use antimicrobials within our lives. I always talk about, I've got a garden full of roses that occasionally get mildew on them. That's a fungal infection, so I might choose to use antifungals on them from time to time. I've got a child, I've got a dog. So I'll be using antimicrobials in lots of different ways, but I'm still the same person. And the messaging for me about AMR and about using antimicrobials prudently need to really align with each other, and that's what we're all about. If you could go on to the next slide for me. Go back again. So our aim is to co-develop stewardship interventions with people and prescribers, and to identify interventions which best support sustained behaviour change. So it's Sarah is our behaviour change expert and health psychologist, and it's about using those principles within lots of different disciplines and contexts. And our first webinar last week or 2 weeks ago was with a patient advocate, a survivor of an antimicrobial resistant infection. And that's we put that up first because it's all about making sure that we have people right at the heart of what we do. If you can go on to the next slide for me, please. And we bring together a range of disciplines, so the arts and the humanities, social sciences, human health science and veterinary science, a range of approaches, and I'm not going to read them all out to you there, but that grey band, pale blue band running through the middle, and then lots of different types of intervention. So today we're talking about infection prevention and control, because prevention is better than cure. If you can prevent people getting infections, then you can prevent them getting antimicrobial infections, because It just is, antimicrobial infections are just infections. Diagnostics, so that we can make sure that people are only giving antibiotics if they've used antibiotics, diagnose the need for them. Biosecurity, communication skills, there's a whole range of issues there using vaccines. So over time, we will be moving forward over the next 3 years, I think it is. If you could go on to the next slide for me. Thank you. So the activities are about building networks and collaborations, exchanging knowledge and disseminating findings across the group, across the network, running some workshops and placements for early and mid-career researchers, also with engaging with the people who are high users of antimicrobials, people who are at risk of antimicrobial resistant infections, people who have experienced that risk of antimicrobial resistant infections. Webinars and events like this today, and joint funding applications, which some of you will have been involved with the UKRI, phase 2, putting together these transdisciplinary bids, and as the network, we've got one that's being produced at the moment. If you go forward to the next slide for me, please. So this is the People Network. If you aren't already a member of the network and would like to, please use that QR code to sign up, or email Chika down at the bottom. She's peopleamr@phc.ox.ac.uk. Without further ado, I'm going to introduce you to Professor Alistair MacDonald. If you go on to the next slide for me, Alistair. Thank you very much. I will leave everyone in your capable hands.
Thank you, Wendy. I'd like to introduce Dr. Abel Ikiri from University of Surrey Veterinary Medicine School to do the first part of this talk. Abel?
Yeah. Yes, thank you, Alistair. Can you hear me well? Good. Over the next 5 minutes, I'll provide a brief background to the topic of today, and pretty much with the intent of highlighting the similarities that we see across the human and animal health sectors with respect to hospital-acquired infections. And as you can tell on this slide, we are reflecting on human healthcare settings, but the emphasis today is about companion animal settings. Looking at the pulse or the similarities across these two sectors is important when we are thinking of interventions and lessons that we can translate across the two sectors to address hospital-acquired infections, but also antimicrobial resistance within hospital settings. And here we can see that hospital-acquired infections are a big challenge in human healthcare settings, with approximately 8% of patients developing a hospital-acquired infection during hospitalization. And the cost can be enormous. In the UK, we can see that the NHS estimates the economic burden of hospital-acquired infection at £2.7 billion annually. And in the US, this cost is up to $4.5 billion annually. And this cost can be worsened by the threat of antimicrobial resistance, which makes hospital-acquired infections even more difficult to treat and control. Next slide, please. Similar to human healthcare settings, hospital-acquired infections are a significant challenge within the veterinary care settings. The transmission of pathogens can occur from animal to animal, from animal to human, but also from human to animal. And as such, hospital-acquired infection may affect not just the animal patients, but also hospital staff during hospitalization, as well as animal owners. And the frequently reported hospital-acquired infections typically include skin wound infections, surgical infections, but also urinary tract infections and bloodstream infections. Next slide, please. Again, here, similar to what we see within the human healthcare settings, hospital-acquired infections within companion practice settings can result in prolonged hospital stays, increased treatment costs, increased risk of antibiotic resistance, and the risk of transmission of zoonotic pathogens between animals and hospital staff, but also animal owners themselves. There is also a risk of litigation, depending on the context. And lastly, there is also loss of trust that can occur between the client and the veterinary practice And this is typically seen in situations where the client may feel that patient care and management is not adequate or optimal, depending on how they see it. Next slide, please. Now, in an effort to counter the potential impact of hospital-acquired infections, small animal practices, but also large animal practices have adopted infection prevention and control measures. And the primary aim is to reduce the incidence of hospital-acquired infections in animal patients and potentially zoonotic infections within hospital staff, but also animal owners themselves. In addition, we of course know that appropriate use of IPC measures can help reduce the risk of spreading antibiotic-resistant pathogens, whether within the hospital environment or within the home settings themselves, in relation to the animal owners and their families. Now, the infection control practices that we see obviously are very context specific, and they will vary by practice. The practices themselves may be documented in form of guidelines, or you could have standardized protocols. And in some hospitals, the standardized protocols may form part of a formal hospital infection control program. Next slide, please. There are several challenges to implementing infection control measures, and that's one of the solutions that we'll be exploring today. And these include inadequate staffing, which can hinder the provision of optimal patient care and subsequently affect the implementation of IPC measures. High patient numbers will obviously worsen the issue of staffing shortages, but also there are other barriers such as inadequate training of staff around IPC measures, poor compliance with infection control measures such as hand hygiene. That's commonly seen, at least within practice settings. And on the other side, there are inadequate hospital infrastructure coming in as barriers. And this could be seen in terms of limited practice space or lack of space for isolating patients that may be deemed potentially infectious during that time of hospitalization. Next slide, please. And I think this is my last as well. Now, next, my colleague Alistair will share a potential solution developed using a transdisciplinary approach with a focus on improving the uptake of IPC measures. And obviously here the goal again is to identify ways we can reduce the risk of hospital-acquired infections within companion animal settings. Over to you, Alistair.
Thanks very much, Abel. That provides very useful context for the next presentation. Can I just get my slide up? Yes, I'm Alistair MacDonald. I'm Professor and Senior Researcher at the School of Design at the Glasgow School of Art. Now, you may be wondering, some of you, what someone from an art school has to contribute to the AMR challenge. I'm a designer by training, and the work I will show today has been funded by the Arts and Humanities Research Council, which has been supporting research into infection prevention and control and AMR for the last decade and a half. And what I hope to demonstrate today is the value of some of the particular expertise that we can bring from the arts and humanities, particularly design, a field not normally associated with AMR and IPC, to help address the AMR challenge by working in a transdisciplinary manner with colleagues from fields that are normally associated with this particular issue and challenge. So as AMR and IPC is everyone's business, but not everyone has the time or expertise to develop a detailed understanding of the mechanisms, pathogens, routes of transmission, mitigations, etc. We wondered if we could take a different approach to changing people's perception of risk of infection by using strengths in speculative thinking, scenario building and storytelling, and visual approaches to make the invisible visible. You should understand that some of what I show you today will illustrate ideas which were early prototypes, which helped give us feedback to help us point in the right direction for further development. So in the first early study, AHRC study, involving a mixed discipline team led by a nurse researcher, we took a very speculative and experimental approach by asking, what if we could use augmented reality in the hospital ward setting to show data in a particular context? What if we could use pathogen goggles, which we could switch on and off? So really kind of building early prototypes to think with and to get some early feedback from the different healthcare staff. In a subsequent study, we were looking at the we were trying to impart the very specific knowledge and evidence base our microbiologist and IPC nurses wanted to convey through a prototype training app, naming specific pathogens, in this case, norovirus, MRSA, and C. diff, and revealing their different characteristics, their reservoirs, their resurgence following cleaning regimes, routes of transmission. So we kind of built a tablet-based training app that we developed through a transdisciplinary team involving microbiology, IPC specialisms, co-design, software engineering, as well as an industry partner and 2 NHS trusts. And we used a participatory co-development process involving 150 nursing staff, junior doctors, nursing students, and cleaning staff to develop ideas through a 3-stage workshop process. We used simulations, workbooks, and interactive tablet-based prototypes. The idea was that the training app had to be effective across the range of individuals working in a hospital setting, not only healthcare professionals, but cleaners, auxiliaries, and visitors, and so on. So although we had some very positive results from this study, we felt the information was too complex to take in, and particularly in a short training period. And we wanted to try and push, find ways of engaging staff better through the particular expertise that we might have in design and the arts and humanities. So that led us on to 2 studies which we conducted with the University of Surrey Vet School. The first in which we developed a proof of concept for a training app for vet staff, and the follow-on project where we produced a beta version which is currently being evaluated through a part industry supported PhD, which I'll come on to later. Both were developed in collaboration with some of Abel's colleagues in the School of Veterinary Medicine. Again, we had mixed discipline teams involving environmental psychology, microbiology, software engineering and program, co-design, and in the first of these studies, companion animal referral practice. However, in these 2 animal-related studies, we took a very different and more generic approach in the work with, while maintaining our making the invisible visible approach. We didn't name pathogens per se, and we didn't want to try and convey the traditional microbiological and IPC knowledge base in the way that they had wanted to impart this previously. We took a more visual approach, given that most non-specialists and professionals don't have much time to invest in training. We asked ourselves as a first step, to what extent could we effectively change the perception of risk of infection through a tablet or a phone-based intervention, an app, in a half-hour training session, the time someone might have in their lunch hour or at the end of a shift. So we approached this by building scenarios involving behavior and risk. So through many hours of video footage, we documented versions of a particular surgical procedure, TPLO, tibial plateau leveling osteotomy, from admission to kenneling, conducted a risk analysis of the interactions and behaviors during each of the different stages, and we found that the pre-surgery preparation stage presented the highest levels of risk. So around this finding, we created a digital model of the small companion animal referral practice, showing the interactions between animals, staff, and the environment. And for this, we modeled 7 scenarios or sequences within the pre-surgery stage. And what we first of all did was we built an interactive 3D digital model based on this footage as a 3-layered tool. The first layer provided the sequences in monochrome, incorporating the risky behaviors we had identified. And here we would invite individuals to try to identify the risks from the footage. We built a simplified view of the model. I think with the video, we found that there was too much distracting detail, and the color provided a bit of a complication. We wanted to show various things against the monochrome. So we would ask individuals to identify the risks in that particular scenario. We would reveal in red, showing the consequences of or where infection might reside, and how that might be transferred by touch. And then we asked the participants to compare their findings with ours, and then we asked about the IPC measures to mitigate these risks that they would take. And then the third layer would be the reveal in green, showing the IPC measures that we would propose would mitigate. So you can see here from the these are sequences from layer 1, just showing with some of the inbuilt risk. I wonder if you can spot some of these at the moment in terms of the transfer of potential contamination, infection, and so on. So we had a number of sequences like this that the trainees would view. And then we would reveal where we thought the risk from the evidence that we had might reside. And you can see, if you watch the hand touching the glasses or their hair or their fob watch, etc., where that potential transfer of risk. And many of these behaviors were innate and perhaps unconscious in the participants, and by revealing things like this, they became more aware and conscious of them. So having asked them in layer 2 to think about the IPC measures that might help mitigate these risks, we would then reveal these in layer 3 and show what might reduce the potential infection risk. So, and then we could compare. They could compare outcomes of the with and without particular IPC measures here. So the initial kind of preoccupation of the team was with the digital model. It was very novel and something that hadn't been seen before, but really it didn't make much sense without structured learning. So we developed what we called a series story. We constructed a learning package, and the script for this series story was supported by the digital scenarios. So rather than the digital scenarios being the primary aspect of this, it was the structured series story and the learning package that became much more important. And the script for this was carefully co-developed through many iterations, and really interestingly, this was principally driven, the content and the critique of this was driven by one of Abel's colleagues, Mark Chambers. So the core question being asked of the trainees during the training package was, what can be done to get Marley into theatre with as little contamination as possible, both on him and left behind in the prep room. So the content was carefully structured. We would maybe pose a question to the trainees. We'd ask them to reflect on a particular issue. This also had a couple of different characters of giving the voiceover to the text on screen. We would then kind of reveal the consequences, and the trainees could compare their what they had identified with what we would recommend. And there would be various elements which, in terms of tutorials or gaming elements, serious games, gaming elements as part of the package. So to give you kind of this is not how the screens actually appeared, but just gives you a kind of taste of some of the text. Start by thinking about what would happen when infection control measures fail, during preparation for orthopedic surgery, and having identified themselves what might be some of the issues, we would kind of reveal. And then, despite the best efforts of introducing IPC measures, there is a particular percentage of infections that do occur, and some may advocate routine use of antibiotics to reduce the likelihood of such complications and what would happen as a consequence of this approach. So the whole package was kind of structured around this kind of dialogue and way of engaging the trainees in thinking and reflecting and comparing and revealing through the digital model. Now, one of the things that you may be asking is how do you engage the team and those participating in the workshops? How do you get the diverse team to involved in the co-development of the digital app? Well, we took a co-development approach through developing particular materials, inspirational examples, and workbook tasks. So the example here from the page from the workbook is how do you think we should show contamination and risk in our digital model? And this was the response from one of the veterinary professors. And we took sequences from the digital model and asked them to annotate these. So this kind of feedback, if you've got a room full of people and they're all giving this kind of feedback, is really very useful. And here the question was, how would you represent the interaction interface and what might this show? And the very valuable contribution here from the veterinary nurse, her page on the left-hand side of the screen, you can tidy that up and present it as it is on the right-hand side. Again, is very useful about what might be useful to the audience, to the participants that you're dealing with. Another of the facilities we used at Surrey was in one of their research labs, was a large interactive screen which would allow the teams and the participants in workshops to annotate over video footage. And you can see in the video footage there that that's much more complex and distracting, say, than our digital model. And again, they could overwrite and annotate the video the digital footage from our model. I don't have time to go into this, but the video will be made available, so you can scroll back through some of these sequences and slides in due course when we put this up. But effectively, what we did was we built a stage prototype from best available evidence. We took that to a workshop. We had certain questions that we posed. We got some really good feedback, and we built that into the next stage prototype, and that was an iterative process until we got to the stage where we could evaluate this, and our environmental psychologists set up the pre and post intervention study. So we got 51 vet practitioners into the study. The stats are there. That's published in this particular publication, and again, you can look at that in your own time when the video becomes available. So we had some positive findings. That we had 92% agree to change the behavior and stated an intention to implement an IPC behavior that aligned with the learning objectives for the workshop through these different measures here. What was really interesting was that when we took the prototype app to the vet students at Surrey, they found that they could easily transfer the kind of learning outcomes and the principles that we're showing here to other procedures, for example, to bitch spaying. So we knew we could change the perception of risk, but how durable was that? And what we didn't know, does this actually change, result in behavior change, and if so, for how long? And does this result in a reduction of infections and use of antibiotics? So this is currently the subject of a part industry funded PhD at Surrey with Plymouth and ourselves contributing to that. And we're looking at the potential change in behavior, reduced incidence of infection, and the reduced use of antibiotics. So we'll be interested to see the outcomes of that. I mentioned that this is, I titled this Transdisciplinary Research, and I think it's a very useful definition by Jung et al. As an endeavour which seeks to integrate knowledge and perspectives from diverse backgrounds to come to a shared and more sophisticated understanding of the problem at hand. It tends to relationship building and communication in ways that transform, reconceptualize, and extend ideas, methods, and theories, and encourages co-creation to rework and implement novel and feasible solutions. So I think we ticked all of those 3 boxes in the course of our work, particularly at Surrey. Just to finish off, really, what's the relevance to the people of the AMR network and the AMR call? What has design brought to the table? Well, I think we've been able to integrate the expertise and methods of a field design not traditionally associated with AMR. I think we're finding truly transdisciplinary ways of working through a non-hierarchical participatory co-development process. I think we're able to recruit and facilitate end users as part of the intervention design team, supported by appropriate materials and activities. I think as designers, we've got a very close understanding of user needs and what works through iterative prototyping and testing. I think we've got skills in communicating complex issues through visual means, an openness to using speculative what-if approaches and building to think. I think we can engage people through scenario building, narrative and interaction techniques, and I think importantly for designers, the use of prototypes to elicit forms of evidence through the testing of hypotheses, bringing insights to the surface. So as I say, there's a couple of outputs that you might be interested in that further detail, the work with Surrey here, and none of this would have been possible without the funding of the Arts and Humanities Council, and the first of the studies also with the Scottish Funding Council. This was collaborative work, and the work of a number of colleagues in a number of different institutions over the 4 studies was vital to our progress and achievements here. So I'd like to thank everyone involved in those particular studies. Thank you.
Thank you.
Happy to take questions. Yeah. Okay.
Yeah, thank you. That was brilliant. I got bubbling full of questions. Before I go, has anyone else got anything that they would like to ask? Or should I kick us off? I'm going to start off by asking about who the trainees were, Alistair. So you talked at one point about them being students, and I wonder whether the students are different to practitioners in practice already, and whether you looked at any differences between. So I would imagine if they're practitioners in practice, you might want to change their behaviour, but if they're students, you might be teaching them the behaviour for a start, and do it once, do it right, I guess. So the trainees is a no-brainer. Will it work also with those in practice already?
I'm not sure if I can, that's a good question, Wendy. I'm not sure if I can answer that because I wasn't close to the trainees. That was the Surrey colleagues at Surrey, so that wasn't part of the particular studies I was involved in, but it was kind of ancillary work that particularly Dinatra Subasinghe, who Abel will know at Surrey. So I wasn't directly involved with the Surrey students in that, but the feedback we got from colleagues in Surrey was that the students were very receptive. I think there are traditional ways of imparting knowledge and theory, and I think they found the kind of interactive serious story and serious gaming aspects of the intervention very engaging, and I think that was a key aspect to I suppose the type of approach we took. Could we use the kind of skills, because the School of Art has a School of Simulation and Visualization, and which is very much involved in serious gaming and simulation and so on. So we were able to kind of bring these maybe unusual skills and aspects of training into these prototypes.
Thanks. Thank you. I see we've got a question from Matt Jones in the chat, where he's asking about whether it was the project was based off real videos of surgery, and I've got a follow-on that goes with that, which is about where the ownership of the IP sits and how those, whether you have an industry type partner. So yeah.
Yes, well, the answer to the first part of the question, yes, we had 15 hours of video following the 3 different versions of the TPLO surgery. So that took quite a bit of time to go through and analyze. But again, the first publication there shows some of the analysis of that video footage that was used as the basis. IP, we've got now a 3-way collaboration agreement with Surrey and the industry partner on the IP. Some of the IP was developed in the first study, and that had a referral practice in that, and they're also included.
Okay, so use of the tool is funded.
Yeah, sorry, I should maybe explain that I can only show so much of this because of the IP today. So what we hope is that the result of the PhD study will give us some useful exploitable results. We have plans to license this in due course. Given the good outcomes, we had plans to license this for use in the future.
Okay. It'll be interesting when you do the licensing to look at which organizations might value it enough to pay for something like this. I can imagine it being very useful in dental schools. Equally, I can't imagine them buying into a product to do this, if that makes sense. So I think that's a really important part of your implementation when you're looking at moving it forward to the next level. I see Sarah's got a hand up.
Yeah, hi, thanks, Alistair. That was really interesting. It's really nice to see such a visual example of a intervention, and I'm sure it's something novel for veterinary trainees to look at as well. I was kind of surprised by the videos because it looks like people are not wearing gloves and aprons routinely in practice at the moment, which I presume is in guidelines and which I presume they already know they should be doing, and I presume they've got access to gloves and aprons. So I find that surprising. Well, possibly not that prescribing, because we probably see it in human health as well. But wearing gloves and aprons is very much of a cultural thing. So you're not going to do it if no one else is doing it. So I just wonder, with the PhD study, are you giving this training to a group in a practice and expecting like a cultural change within the practice rather than just giving it to individuals?
Yeah, I think I very much agree with that. Each practice has its own culture, and that's important to recognize. So, and again, you can't change one individual in a practice with that's not, you got to change the culture of the whole practice. So, yes, there's no further development of that package. We're not changing the intervention as it were for trial in the package in the different practices. That is very much as it was. We wanted to halt any further development on the package until we got some kind of results from that. So we recognize there's a lot more we could do and add to that, and we could show different kinds of scenarios, different kinds of procedures and so on. But again, we would need more funding to do that. I think the kind of generic approach that we took is very transferable to other procedures and scenarios. So it's a kind of proof of principle, really, we have through this beta app at the moment. So we're looking for some more positive outcomes before we seek further funding for that.
I think there's always this tension between a kind of training intervention and getting people to use and implement the training intervention. So people like the training, you know, they like a kind of novel format. They take the information on board, but then they don't necessarily do it in practice. And so sometimes in primary care, in general practice, we develop implementation interventions. So you try and get the kind of senior leaders on board to kind of champion, like, this training package is good. This is how we're going to change as a practice, because, you know, we're going to get these important outcomes to us. So it might not be so much changing the great content you've got already, but just thinking about what could be added implementation wise to get people on board.
Yeah, very much.
Yeah, and if you can get them to buy into the package, Alistair, then they've put their money where their mouth is, and so that's a really important part of that implementation package. Yeah.
Just a quick addition to that, Wendy. I thought Sarah raises a very important point there in regards to compliance. This is something that, just as we see it in the human healthcare settings, it's a big issue within the veterinary care settings. I know within the human healthcare settings, we always hammer on washing of hands as being the simplest but most effective way of preventing or reducing the risk of transmission. But so is the case as well within the veterinary care settings. And you find that even with all these washing stations, hand dispensers, and all that, still compliance is an issue. And I think looking at it from this project's point of view, I see two potential benefits here. One is the training of the students. It's always very difficult to train students, especially on aspects that may appear a little abstract. And this kind of training that Alistair has just described is very engaging. So that helps us get the students on board in terms of understanding, appreciating the relevance of infection control. But then how do we take it to the field? Like Wendy asked earlier, how do we take it into practice? And I think that's where there is a little bit of a gap. And I think we may have to draw on some of the lessons, Sarah, that we just mentioned, their implementation interventions. How do we get those that are actually in practice to do it? Because that's a big blocker that we continue to see both within small but also large animal healthcare settings.
Very much so. Is there anyone else who would like to come off mute and ask any questions? Not even questions, any thoughts? Has it stimulated any thoughts in anyone's mind that they would like to have a go at implementing it in their own setting? I'd be fascinated about using it with a dental setting. We just need to find the funding to do the videos for a start. Alistair?
Yeah, I'd just like to pose a question. That's something that I raised during the presentation there. In the hospital-based studies, we're very much kind of following the lead of the microbiologists and the IPC nurse specialists in terms of, you know, their knowledge base and what they wanted to convey. You know, and that was kind of information heavy, you know, as it were. This is what MRSA does. This is what norovirus does. This is, you know, how you can mitigate this. This is how it transmits and so on. So we found quite quickly that the information load was really heavy and quite difficult for non-specialists to handle, although we had some positive results from that. So I'm kind of interested to get some feedback on the kind of approach that we were trying to adopt here, is to kind of use that as kind of background knowledge and evidence, that knowledge base, but you know, try and take a quite a different approach. You know, in a sense, you know, this kind of area of transdisciplinary working, that requires a certain amount of if I would use the word modesty, it's not quite right, in a sense of yeah, let's just kind of try something new. And I suppose where we were very fortunate in the 4 studies was really having experts in those traditional fields of IPC and AMR, microbiology, and so, who are kind of willing to kind of stand back a bit and kind of let's see what could be offered, because, as I say, this is everyone's business. And you know, we're trying to engage some of in the hospital settings, the cleaning staff, for instance, a very important part of the ecology of the hospital. You know, and you know, you only need one person to break the chain of protection, and you know, the whole thing collapses, as it were. So I'm just kind of interested if there's any responses to the particular approach that we took through the kind of the 2 studies in Surrey, using a kind of non-traditional approach to training. If there's any feedback on that, I'd be very interested.
Yeah, it'd be interesting to hear that, Alistair. I know there's a study from Australia where they looked at what do patients want to hear and what do the experts want to tell them, and this is a complete mismatch between the two. And so what you've done, you've taken it very much from the audience's perspective, if you like, rather than from the teacher's perspective. Jim, I'm aware you've got your hand up. Yeah, let's go to Jim, and then if anyone's got any comments to come back to Alistair sort of with the feedback, then that'd be great as well. Hi, Jim.
Thanks, Wendy. Thank you both for that talk. It was really interesting. I was just thinking, Abel, when you were talking there about how to actually make sure that people implement these changes, whether, given everyone's got access to smartphones these days, once they've tried to internalize and think about what they're doing, whether each of the participants could then create short videos in their own practice. I'm just thinking, you know, with that dog that was being prepped for surgery, it almost looked like the camera could have been propped up on the anesthetic machine, and whether they could make short videos themselves, having thought they were implementing the changes, and then they could kind of annotate it themselves and reflect on, oh, actually, I see that I touched my face again there, or I've touched the table there. And then that might make the kind of more innate harder to change things, rather than simply, yes, I remembered to put my PPE on, whether that might allow them to reflect on those things more easily. Just a thought.
Like an audit,
thank you both.
An audit tool. Yeah, an audit tool would be really great like that. One of the things that was running through my mind was when I was a dental student, and I remember it was usually the dental nurses were telling us when we touched our face, for example, when you said about touching your face, and you do it instinctively, you don't realize you're doing it. So when someone plays a video back, then that's really useful of you doing it. But when it's someone else telling you that you've done it, sometimes the reaction you get is, I didn't. And it's almost like having that third party objective view on it, rather than it being you versus somebody else teaching you that. So that was one of the things that was occurring to me about how useful this could be. Yeah.
I think that was a really good proposal, Jim, that you made there. You know, this idea of kind of self-reflecting, you know, during practice. You know, what did we actually do? Yeah, and using that as a tool for reflection and further training and development.
Sarah?
I've got a bit of a tricky question that you might not be able to answer, Alistair, but I'm just wondering how much this cost to make and how long it took, given that, you know, you had lots of prototypes over time.
Yeah, when the Surrey work was 200K and 2 years, which is quite modest, you know, given FEC. Yep. The second one, the Viz, where we're taking the AMR sim proof of concept to beta, was only I think 79K and 9 months. Because we had got the team together, we reduced the team size for the second Surrey study. Effectively, there were 5 or 6 of us. We were very in sync. We did that in 9 months. We did, you know, 3 workshops. Well, perhaps more. I think we did 5, maybe 5 or 6 workshops over that period. You know, it was very intense, but very carefully prepared. We knew what we were doing. We knew what we wanted to get, and Yeah, I think the kind of results kind of surprised us, but we're very pleased to have done taking the findings from the first study through to beta version in 9 months, because that's all the funding those particular schemes would allow. We would have done we would have perhaps done a bigger intervention study in the first AMR sim proof of concept, but the funding limit, that was an AHRC AMR related call, but the time and budget were limited for that. So I think we got good value for money in research terms.
Yeah, that's 9 months is fast to do 5 workshops and on 80K. And how did you choose the industry partner you worked with?
Well, in the first study, that was again through Surrey. They had an animal practice that was very innovative, referral practice. It was very innovative and was kind of interested in kind of new tech, new ideas. So that was one of the professors at Surrey who got them on board. And again, for the PhD study, again, that was contacts through Surrey with one of the professors there. So yeah, all of that side of things was, we have no kind of reach into those spheres. So it was absolutely. I mean, I think it shows you the willingness of the colleagues in Surrey to kind of really, accommodate and adopt something quite experimental and quite unproven. And I think this is a big difficulty for us in the arts humanities to kind of break into these kind of fields. So we need partners, colleagues who are as co-investigators who are really, kind of open to ideas, to are kind of interested in risking and then kind of pull in the right people. So it's a great way to work.
Abel, Alistair, that has been a fantastic webinar, fantastic morning. Thank you to everyone in the audience for listening in, for taking part, for sharing thoughts. If you want anything to get involved with the network anymore, then remember it's people AMR, help me out, Chika, at ox.ac.uk, phc.ox.ac.uk. Right, Alistair, you've got your hand up again.
Yeah, just maybe we could just have a word about the videos from the webinars being available in due course, I understand. So I'm not sure where they will be available, but probably through our People AMR network website. Perhaps I could be corrected on that, but that's my understanding. So you'll be able to go back through these videos and look at the various slides at your leisure.
Yeah, it will be on the. We're working on a more elaborate web page. So once that is launched, all the videos from all our webinar series will be found there.
Perfect.
Thank you so much. Yeah.
Thank you,
Thanks,
everybody.
Wendy.
Take care.
Thank
No
you,
worries
everyone.
at all.
Thank you.
Bye-bye.
Bye.